Okay, so if anybody has any questions or anything like that, or you can't hear me at any point, feel free to just pop something into the chat or raise your hand. But I'm assuming that you all can hear me.
I can hear you.
Okay, perfect. Okay, so I unfortunately don't have an introduction ready or anything like that, but I think most of you on the call would know who I am. My name is Leah, and I'm one of the pharmacists working in the pediatric and neonatal ICUs at Children's. Oh, Christy just giving me a thumbs up. Thanks, Christy. Okay, so today we're going to have a joint presentation between myself and Ravi can give a little bit of an introduction of himself if you would like, because unfortunately I don't have all of his credentials memorized. But we're going to present today on a little bit of a vasoactive medication review. So I'm going to do the first half of the presentation. We're going to talk a little bit about the actual drugs that we most commonly use, and going to give you a little bit of an overview on, let me make sure I can go ahead here. Okay, yeah, brief overview on circulatory physiology, kind of in the setting of shock. We're going to talk about the medications that we most would commonly see in the PICU, and then folks who are attending from the NICU, you're going to notice a lot of overlap as well. And then we're just going to talk about the receptor affinities and some other pharmacological details. So we're going to talk about the most common medications that we would use within our units. There are some vasoactive medications that I'm leaving off of the list because we very rarely use them. And then once I'm done with this first piece, Robbie's going to take over and present some kind of more real life applications of this information. So I'm a little bit of a nerd, so I always like to start a talk with a little bit of the history, just so we kind of know how we got here. And because it's kind of fun with the gift of hindsight to sort of laugh a little bit at our forefather scientists who sort of, got us to where we are today. So before the current knowledge of endogenous catecholamines was established, scientists and medical professionals in the 1800s were kind of unwittingly using the body's catecholamines in therapeutic ways. So in the mid 1800s, the leading reference book at the time on the treatment of asthma was published, and it described very effective treatment of asthma with strong stimulants. So that could have been things like strong coffee, as well as violent emotion, where the doctor would make people feel sudden feelings of intense stress, and that would relieve the asthma attack. So obviously at the time, this was, very novel therapeutics. But, looking back in hindsight now, we can sort of see kind of why those things worked the way that they did. And by the end of the 19th century, scientists and labs were noting connections between the adrenal glands and other organs of the body. German scientists of the time noted that they could make intestinal peristalsis stop by electrical stimulation of the adrenals. And this guy here, British physician Dr. George Oliver, discovered by experimenting on his own family members that an extract taken from the adrenal glands of a cow or a sheep, when injected under the skin, again, of his family members, would cause the narrowing of the radial artery. And this particular tale is a little bit of potentially a little bit apocryphal, but we do know that in 1895, that guy there, along with another scientist named Schaefer, published a 47-page paper detailing their experiments using these adrenal extracts from animals. And they found that when they injected these extracts, people had narrowed arteries, increased blood pressure, and caused reflex bradycardia. And this report was absolutely sensational. People were freaking out, huge frenzy of research around this topic. And the top guy, Dr. Oliver, started trying these adrenal extracts in all kinds of patients with all kinds of diseases, because you could just do that back in the day, just sort of go around injecting people with random stuff to see if it worked. And he also immediately started working on getting an extract from the pituitary gland. So not only did he essentially discover adrenaline, but he also discovered vasopressin. And starting a few years later, epinephrine was used in kind of its first therapeutic applications like asthma, although not for the bronchodilator effect that we would, get to be discovered later and that we would primarily use it for now. The initial thought is that the epinephrine would constrict the blood vessels leading to the airways and therefore reduce airway edema. And it was added to local anesthetics to prolong their action. And so basically the rest is history, as they say. And further scientists in particular areas were able to sort of continue refining these uses of epinephrine in different body systems. So before we get into specific agents, I kind of want to set the scene a little bit in terms of our basic circulatory physiology so that we can better frame the effects of the drugs that we're going to talk about. And we're going to break it down into the pretty simple bare bones, and then Ravi's going to talk about framing that into the specific clinical scenarios that we would commonly see. So when we're using vasoactive medications, most of the time what we're treating is shock. And shock can be precipitated by a number of factors or clinical conditions, but no matter the cause, the end result is a lack of end organ perfusion. And it's a common belief that shock means low blood pressure, but that's not always the case. Hypotension can be present, but patients who have what we call compensated shock, where their body is able to keep blood pressure numbers looking okay, they're doing so, but they're sacrificing adequate perfusion to some organs in order to do that. So that's where the true definition of shock is adequate perfusion of tissues, not necessarily an adequate blood flow to tissues, but that the tissues are not getting enough oxygen to complete normal metabolism. And that can kind of come from a couple of different avenues. So if you picture, having the tissue layer, this is my very great graphic design skills being shown off in PowerPoint here. So if you imagine tissue with the blood vessels feeding it there at the bottom, that can come from either inadequate blood flow, like an actual reduction in the volume of blood making it to those tissues. It can come from a reduction in the oxygen that's actually carried to the blood. You can see like the lesser red dots there of the oxygen being carried along the hemoglobin, or that the tissues themselves are not able to use the oxygen that's delivered to them. So I made the cells kind of green so that they were sort of represented as sickly. So you can have actual tissue dysfunction. That means that even though adequate blood flow and adequate oxygen are making it to those cells, for some reason, they're not able to adequately use it. So when that shock state has occurred and you're seeing that lack of adequate perfusion to the major body organs, that's when you start to see those clinical effects of those tissues not being able to function as they should. And that occurs all around the body. We're probably all very familiar with the way those things manifest. You see the kidneys can take a hit, produce less urine, reduce filtration capacity. So you'll see serum creatinine rise. You'll see the liver take a hit. AST and ALT can rise if the liver parenchyma is underperfused. The brain can be affected as well with patients experiencing confusion or becoming untended, and the gut can also take a hit and have reduced mobility and absorption. And don't forget that the heart itself is a muscle too, and that muscle needs its own oxygen supply. So in shock, the heart itself can be underperfused, and then you can kind of get into this self-fulfilling cycle of worsening circulation, right? Most otherwise healthy people are able to compensate pretty well in the beginning stages of shock. So once you start to see this result in organ dysfunction, the situation's usually quite serious. And if we think about shock as a failure of the circulatory system, which can be caused by many different instigating factors, you can have sepsis, blood loss, severe dehydration, heart dysfunction, et cetera. We all know about the different subtypes of shock. The actual physiologic basis for most of these shock states comes down to the principle of cardiac output and how the body produces cardiac output. And there are a few shock states, like I mentioned previously with my sickly little green cells, where it's actually not a problem with the circulatory mechanics. It's the cells themselves. And you can see that with certain toxins like carbon monoxide or cyanide or mitochondrial disorders. And it's just those sick cells that can't use the oxygen that is being adequately provided to them. But the most common shock states that we would see, so sepsis, severe hypoxia, cardiac failure, all that kind of stuff, they do come back to a failure of one or more components of these principles of circulatory physiology. And so there's a couple of key equations that we can use to demonstrate these physiological aspects. So you've probably seen this one that's up on the slide before, and that's that blood pressure is defined as cardiac output multiplied by systemic vascular resistance. So any pressure, including blood pressure, is the force exerted over a particular area. That's just the way it's defined in physics. So for blood pressure, that's represented by how much blood the heart is pumping out and how much area there is in that blood vessel tube for the blood to exert force on. So systemic vascular resistance is how much resistant force the blood vessels offer against the flow of the blood being pushed out by the heart. And, SVR can be affected by a ton of physics related factors, how long the vessel is or how long the tube is, the viscosity of the blood being pushed through it, how large or small the diameter is. And if you think about moving liquid through different tubes, you can see that kind of analogy. If you have a really wide open storm drain, water flows easily with low pressure. But if you have that same water flowing through a really tight garden hose, you're going to have an interior available area, that area is going to be much smaller. So the pressure is going to be much higher when you're moving that same volume of water as you were through the big wide open storm drain. And it's the same with blood. If your circulating volume stays the same, the blood pressure will be higher when the vessels are squeezed tight than it would be if the vessels were wide open. And so cardiac output, or how much blood the heart pumps out every minute, is equal to the heart rate multiplied by stroke volume, which is the volume of blood pushed out of the heart with each beat. The volume that the heart can push out is also dependent on a few things. There we go. So cardiac output, heart rate times that stroke volume, which I just said. So heart rate, obviously how fast the heart beats, but that stroke volume, how much blood is pushed out with each beat of the heart is dependent on a few things. So preload, which is the volume of blood available in the ventricle at end diastole. So how much blood is available in the ventricle at the time when it's maximally full, and how much the ventricle is able to stretch to prepare to bounce back like a rubber band. Contractility is how hard the heart overall can squeeze, how much force it can put into that squeezing effort. And afterload, which is the resistance that the heart pumps against. Afterload sounds a lot like SVR, and SVR plays a big part in afterload, but afterload also includes things like the resistance produced by the valves of the heart themselves, or the intrathoracic pressure that the blood encounters on the way out of the heart. So there's a couple other things that also contribute to afterload, but SVR is one of those things. You can kind of see how all of these factors interplay with each other, but it really comes down to those fundamentals of blood pressure is equal to how much blood the heart is putting out at any given moment times how much resistance it pumps against. And then you can break down that how much blood the heart is pumping out into how much it pumps out and how often it pumps it out. And because all these factors are directly related to each other, when one gets higher or lower, the overall blood pressure gets higher or lower as well. So for example, if all other factors remain the same and your heart rate goes up, cardiac output will go up and then blood pressure will go up as well. And conversely, say if SVR goes down, your blood pressure goes down too. And your body's always in tune with all these factors and makes adjustments where it can in order to compensate for, any negative physiologic changes. So if your body detects a decrease in SVR, like in the beginning stages of warm shock, where you're having that big vasodilatory pooling effect in your periphery, when your body detects that decrease in SVR, it's going to try to compensate. So it's going to try to increase cardiac output in order to keep your blood pressure at, sort of a happy level and keep it at homeostasis essentially. So based on our equations, it will do this by increasing cardiac output, which can be done by making the heart beat faster or increasing stroke volume, and the heart might start trying to beat harder. And this is the kind of physiologic process that can go on in early shock prior to it becoming clinically apparent. And this is why hypotension is not always present in a shock state. Otherwise, healthy people can often compensate for some period of time until their circulatory system becomes overwhelmed and the compensatory mechanisms are no longer adequate. And this ability to compensate can vary amongst people, amongst disease states, reasons for the shock, et cetera. So, ultimately, once that circulatory system becomes compromised and the body can't maintain those compensatory mechanisms anymore is when you see that tanking of the blood pressure. So I thought it would be helpful to summarize these points with kind of a graphic representation of the circulatory system for people who are more visual learners. So coming back to that core equation of blood pressure equals cardiac output times SVR, this is kind of where in the circulatory system those primary components are taking place. So cardiac output, you can see I'm pointing at the heart. Systemic vascular resistance, we're pointing to the vascular beds. And then as a reminder, we can break cardiac output down into heart rate times stroke volume. So before we get into the drugs that can affect these circulatory system components when they start to fail, we're going to need to detail the important receptors that are key in these processes. Most of our vasoactive medications act on one or more of the following receptors in the autonomic nervous system. You have your alpha 1, beta 1, and beta 2. Alpha-1 receptors are located throughout the body, but our relevant locations for our purposes here are largely in the systemic vasculature. The agonist effect, or what happens when you stimulate that receptor as opposed to blocking it, is vasoconstriction. And beta-1 receptors are mainly located on the heart itself, and stimulation of them results in a higher heart rate, which is called positive chronotropy, chrono meaning time, and a higher contractile force in the heart, which we call inotropy, positive inotropy. Beta-2 receptors are located in the systemic vasculature similar to alpha-1, but their stimulation actually causes dilation of those vessels. And so you can kind of see how these receptors almost categorize themselves into different aspects of the circulatory physiology formulas. The beta-1 receptors are located on the heart, so their effects will affect the cardiac output side of the equation via the heart rate and stroke volume piece, and the beta-2 and alpha-1 receptors in the vasculature play a role in affecting the SVR. And we're going to keep coming back to this diagram as we go over the different drugs to help frame that information. And a little bit of a caveat, this is kind of stripped down. Obviously, these receptors exist in other places in the body as well, but this is just kind of what we want to focus on in terms of comparing these drugs to each other. So let's get into the drugs. Obviously, I want to start off talking about epinephrine. We talked about at the beginning of the presentation. It's basically the OG. And endogenously produced epinephrine comes from the adrenal glands. And this is reflected in the name itself. When you break down the name epinephrine, it literally means a compound that belongs to the above kidneys, which is the adrenals. And same deal if you break down the name adrenaline. Similarly, a compound belonging to the near kidneys, which makes sense when you look at a picture of kidneys and adrenals. So epinephrine exerts its effects on all three of those receptor types that we've talked about. So it can perform all three actions: increase cardiac output via stimulation of beta-1 receptors, and increase SVR via stimulation of alpha-1 receptors. But it can also decrease blood pressure by vasodilation through the beta-2 receptors. And these effects are variable based on dose. So we're going to talk a little bit about that in a little bit more detail. So at lower doses, epinephrine's effects on the beta-1 receptors are prominent, and they cause an increase in heart rate and stroke volume. So those increase cardiac output. Both alpha-1 vasoconstrictive and beta-2 vasodilatory effects are present too, but they kind of cancel each other out. So there's overall like a net little to no effect on SVR overall. So the overall net effect of a low dose of epinephrine is then a higher blood pressure due to higher heart rate and increased cardiac contractility, because of those effects on SVR are kind of canceling each other out. At higher doses, the beta-1 effects continue to increase cardiac output, but and we have the green arrow there, increased cardiac output, but the alpha-1 vasoconstrictive effects start to outweigh the vasodilatory beta-2 effects. And so this results in a net increase in SVR, which also contributes to blood pressure elevation in addition to the increase in cardiac output. And a quick side note, epinephrine is actually known to cause elevated lactate production, and at least part of this is occurring in the liver as aerobic metabolism, and it's not always necessarily an indicator of worsening hypoperfusion to tissues. So if you're on high doses of epinephrine, just kind of got to keep that in the back of your mind that this could happen, and that rising lactate alone in the absence of other clinical signs of worsening shock might not be an indicator that the epi's not working. And one major drawback of epinephrine is its pro-arrhythmic potential at high doses, because you're really cranking up the effects on those beta-1 receptors in the heart. So next up is norepinephrine. It's extremely similar in structure to epinephrine, and the body can actually convert it to epinephrine using a specific enzyme. In addition to being released by the adrenals, it's also present in the brain and plays an important neurotransmitter role. So norepinephrine exerts its main effects on the alpha-1 and beta-1 receptors. The alpha-1 receptor stimulation is kind of the most prominent effect of norepinephrine. We know that when you start norepinephrine, you're getting that really strong squeeze on the peripheral vasculature to raise that SVR. And in addition, similarly to epinephrine, the beta-1 receptor stimulation promotes a higher heart rate and stronger contractility of the heart, to result in a higher cardiac output. So if we see here, you've got that really, really big green arrow for increased SVR and a little bit of a smaller green arrow on the cardiac output there. The alpha 1 effects on the SVR are generally much stronger than the beta 1 effects on increasing cardiac output. So when the heart is seeing a significant rise in blood pressure due to the significant squeeze from the heightened SVR, you can have a little bit of a reflexive slight drop in heart rate. So sometimes at lower doses of epinephrine, even with that beta 1 stimulation, there won't be an actual increase in that cardiac output piece, kind of a net neutral effect. But this can be very variable amongst patients and can depend on their kind of heart, their volume status, that kind of thing. And especially as you get into higher doses of norepi, or you've been on it for a long time and your body's really saturated with it, those beta 1 effects can become more prominent and cause an elevation in heart rate and cardiac output. So the effects, similar to epinephrine, you can see a little bit of variance in terms of low versus higher dose. Norepi also actually does have some weak effect at the beta 2 receptors, which would cause vasodilation, but that effect is far outweighed by norepi's very, very potent effects at the alpha 1 receptors. And similar to epinephrine, norepi can cause cardiac dysrhythmias at higher doses due to that myocardial toxicity. Next up is phenylephrine. So it's not super commonly used in the PIC. We most commonly would see it on postoperative patients who have been started on it in the OR who are coming down to PI post-op, but we do see it with some regularity, so I did want to include it here. And phenylephrine is basically a pure alpha agonist, which means that its clinically relevant vasoactive effects are caused only by activity on the alpha 1 receptors. And a very strong stimulation of those receptors causes significant vasoconstriction, causes an increase in SVR, and therefore an increase in blood pressure. This is very similar to what we just talked about with norepi, but because it has none of the effects on beta receptors to also stimulate that increased heart rate, you'll often see that potential for that reflex bradycardia with phenylephrine. So the body detects that this drug is causing a sudden increase in the SVR, a little bit more common if you're bolusing phenylephrine than using, kind of lower continuous infusions. But because the drug isn't offering those beta 1 effects to help increase the heart rate, there is sometimes a reflex bradycardia when phenylephrine is given. Although phenylephrine is very similar in action to norepi, it's less potent. So you often require higher doses of phenylephrine to get the same effect as a lower dose of norepi, which is likely why we kind of use norepi more preferentially in the ICU as opposed to phenylephrine. And now to vasopressin. This big old beehive of amino acids is also endogenous to the body. It's also known as antidiuretic hormone, or ADH. It's largely synthesized by the brain in response to changes in things like serum osmolarity and et cetera, but it can also be released by cardiac myocytes or the adrenal glands when they detect. If they detect a lot of other catecholamines floating around the body, this is a little bit like a panic button that the heart can push to kind of release the vasopressin to kind of help the situation out. So vasopressin has a ton of different effects in the body, but when we're looking at this circulatory system in particular that, we've kind of been using as our reference diagram, it doesn't actually act on any of these alpha or beta receptors that we've talked about so far. Instead, it acts on these specific vasopressin receptors called V1 and V2. So this diagram's not super useful. So I'm just going to go back to these kind of baseline equations we were talking about in the setting of the circulatory physiology. So affecting those V1 and V2, V1 receptor stimulation results in vascular smooth muscle contraction, and stimulation of V2 receptors results in increased free water reabsorption by the kidneys. So when you're thinking about a shock state, the V1 receptor effects are primarily what you're going for there, and that vasoconstriction can cause a marked increase in SVR and occasionally cause a small reflex decrease in cardiac output, but the overall net effect is to increase that blood pressure. Higher doses of vasopressin are generally more effective at constriction and therefore raising the blood pressure. But the main concern with high dose vasopressin is that it can cause vasoconstriction where you don't really want it. It can start to constrict the coronary arteries at high doses, and it can also constrict pulmonary vasculature as well. And the significant vasoconstriction that you can get even in the periphery can put patients at risk of ischemia in their peripheral, like the tips of their fingers and toes, especially in combination with norepi. Sometimes, when we had the adult patients in ICU, I think that's a little bit more common, where the tips of their fingers and toes can start to turn black because they're just not getting any circulation at all. It also has the potential to cause hyponatremia due to the increased free water retention. Anecdotally, we kind of see that more probably on the neonatal side than we would in the PICU side, but the potential is there. Moving on to dopamine, if you're starting to notice that all these molecules basically look exactly the same, you're probably right. Since a lot of these compounds exist endogenously and they're not synthetic drugs, we're just giving the body more of the substances it already has. A lot of them are precursors to each other. So dopamine is actually a precursor molecule to norepinephrine in the body. It's converted to norepinephrine by dopamine beta hydroxylase. These similarities in the molecules are a lot of the reason why there's so much overlap amongst which receptors they act on and the actions that they have. But surprisingly tiny differences in the molecule can affect potency and the types of receptors that it goes to quite a lot. So dopamine has lost some of its popularity in recent years, and that's largely due to how variable its effects are. The action of dopamine varies wildly based on the dose being administered, and it's a very dirty drug. It affects a lot of different receptors, and it's actually fairly unpredictable in the results that it produces at low doses. There we go. Low doses, so kind of that 0 to 3 microgram per kilo per minute range. It largely stimulates D1 and D2 dopaminergic receptors. So again, these are not receptors that are included on this diagram here. But the effective stimulation of those receptors is actually to vasodilate blood vessels in vascular beds, like the renal, cerebral, mesenteric, those other types of peripheral vascular beds. So at low doses, dopamine actually often produces a vasodilatory effect and can actually cause hypotension. And that's kind of partly why I have a personal vendetta against titrating dopamine right down to super, super low doses before you turn it off. You might actually give your patient a soft blood pressure by running low dose dopamine. When you're titrating it down and you go from 5 to 4 to 3 to 2 to 1, once you get down in that under 5 area, you often can give your patient a soft BP when you run that low dose dopamine, which means you just have to turn it back up and you can never really turn it off. I often just, once you get down to that below 5, just try turning it off and see if the patient can tolerate being off of it. There was a bit of a theoretical concept going around for a while that low dose dopamine might actually be renal protective due to that renal vasodilation. And that was talked about a lot in a lot of critical care circles, but that has never actually been conclusively proven to occur in studies to have that protection of the kidneys. That's low dose dopamine. At medium doses, kind of between that 5 to 10 microgram per kilo per minute range, dopamine kind of weakly plays at a lot of different receptors. It retains some of those vasodilatory effects with those D1 and D2 receptors that we discussed on the last slide, but it also starts to have effect on both beta 1 and beta 2 receptors at this point. As we know, beta 2 stimulation would result in further vasodilation, so that would bring your SVR down and cause a further decrease in blood pressure. But beta 1 stimulation will result in a higher heart rate and contractility. And those beta 1 effects start to predominate as you move into the higher doses of dopamine, resulting in a net increase in blood pressure because that cardiac output piece starts to become the most dominant effect. And then at high doses of dopamine, so 10 to 20 microgram per kilo per minute, we've left those vasodilatory dopaminergic receptor effects in the dust. Now we're just seeing the alpha and beta receptor effects. And the alpha effects are dominant at this stage. So you have an increase in SVR because of vasoconstriction. And that's contrary to what we see with the lower doses of dopamine. And this vastly outweighs any residual beta 2 effects to produce a vasodilatory effect and a decrease in SVR. So because the alpha receptor effects are the most prominent there, you get an increase in SVR. And then you still also see some beta 1 effects at this point, which continues to increase your cardiac output. But at doses this high, dopamine has quite a lot of proarrhythmic potential due to the beta 1 receptor stimulation. So it's not super popular to crank it up that high. And ultimately, dopamine's a very dirty drug, unpredictable receptor effects, especially when changing doses, and escalating dopamine higher and higher isn't necessarily super productive because you're hitting an entirely different set of receptors, entirely different mechanism of action can come into effect when you increase or decrease the dose. And these different actions are unpredictable. The dosing cutoffs that I suggested for those kind of low, medium, and high, they're not firm rules. There can be a lot of interpatient variability on when the different receptor effects come into play. So rather than thinking about the different receptor effects of dopamine in terms of, like a very firm categorization of different doses giving you different effects, it might be kind of a better way to think of it in terms of a continuum. Doesn't really have a well-defined dose bracketing for each patient. It just, these effects sort of like melt into each other. And that unpredictability is why, is one of the major reasons why dopamine's fallen out of favor in recent years. So second last, we have dobutamine. Dobutamine is the only one we've covered so far that isn't endogenously produced in the body. It is a synthetic compound, and it was created in the 1970s, initially based on isoproterenol, which is another vasoactive medication and one that we're not covering in this presentation just because we use it rarely, very rarely in our ICU. And dopamine exerts its primary effects on the beta-1 receptors, causing positive inotropy, making the heart beat more effectively, and may also increase the heart rate somewhat. So this causes an increase in cardiac output, but it also has weak effects at the beta-2 receptors, which are vasodilatory, and alpha-1 receptors, which are vasoconstrictive. And these mostly cancel each other out, but the usual net effect is a little bit more towards the beta-2 side and results in a small overall vasodilatory effect. And because of this, blood pressure may actually drop even with increased cardiac output, but it's usually a fairly minor effect. And it is interesting to note that running dobutamine for prolonged periods of time can cause desensitization of the beta-1 receptors in the heart, which means that after a period of time, the drug won't work as effectively if you've had the infusion on for a very prolonged period. And then again, similar to other drugs we've talked about, it does have the potential for dysrhythmias at higher doses. And last but not least, we have milrinone. Milrinone, like vasopressin, acts on different receptors than the ones we've discussed for most of the drugs here. So again, rather than talking about its effects in the setting of this graphic, I'm just going to talk about its particular mechanism. So milrinone exerts its effects by inhibiting a separate enzyme called phosphodiesterase 3, which we shorten to PDE3, and you can see it right there. And you do not have to memorize this whole cycle here. But PDE3 is part of an intracellular signaling pathway that is outlined there. And it regulates cardiac and blood vessel contractility. And it works by breaking down cyclic AMP, which you can see just to the right of PDE3 there, in cells in order to modulate the balance of cardiac and vasculature contractility and dilatation. So it helps to kind of keep that balance. But when you block PDE3, the concentrations of cyclic AMP increase in the cell because PDE3 isn't there to break it down. And when you have higher concentrations of cyclic AMP or CAMP, you can have smooth muscle relaxation, dilation in the vasculature, and in actual cardiac myocytes, the increased concentration of cyclic AMP stimulates positive inotropy to increase heart contractility. So the net overall effect, if we go back to these equations, is similar to that of dobutamine. You have an increase in cardiac output and an increase in forward flow, alongside a little bit of a drop in blood pressure. And this hypotensive potential is a little bit higher with milrinone generally than with dobutamine because it does have a little bit more potent effect on that vasodilatory kind of piece. So that was a lot. And I recorded this for a reason because I feel like this is something that people might want to refer back to. But if you've been at work over the last couple of days, you might have noticed a little baggie with some bright orange cards in them at the front of the nursing desk in PICU, kind of taped to the whiteboard there. So this is a pretty busy table, but I did just summarize what we all just talked about into a bit of a reference table here. And I did print it, laminated it, and hole punch them so that people can add these to their lanyards or badge reels if they would like, similar to the APS dosing reference cards. And this is not the end all be all of references. This just reflects general information. And there's even suggested dosing titrations on the side, kind of giving people an idea of what our usual starting doses are, what our usual titrations are. And for any nurses who are taking verbal orders or physicians who are writing orders, there's a little bit of a side column there to suggest how you might titrate these agents and whether or not, at least in PICU, we can order them as like an MD order that nursing can titrate within a certain range, or if a physician usually orders each increase. Yeah, and usually nursing is only really titrating epi and norepi, or maybe phenylephrine without like a specific physician order every time, but that's just usual practice within the PICU. So they're free, available at the front of the nursing desk in PICU if anybody would like one. And I think the last time I gave a talk to the NICU group, they expressed some interest too, so I can definitely drop a few off in NICU as well. And just a quick caveat, the one final thing I would like to say is that all of this physiology that I just talked about, that discussion exists in a vacuum. There's a lot of patients with a variety of concurrent conditions that can affect physiology and make the drugs not work as described under perfect conditions. So take that information with a grain of salt. Always consider the patient in front of you because they're little and they probably didn't read the textbook yet. And so I'm going to hand it over to Ravi. I can see that there's some messages in the chat. There might be questions, but I'm going to hand it over to Ravi to present his portion of the talk, and then we can address questions kind of afterwards. So with that, and I'll probably make my slides available on our SharePoint as well, just so people can view them at their own pace. But Ravi, if you're ready, I'll hand it over to you.
Is it displaying properly, Leah?
Yeah, looks good.
Sounds good. So thanks for coming. So I'm Ravi. I'm one of the, I guess I'm the newest pediatric intensivist here. I'm also part of the Department of Pediatric Anesthesiology. Did my anesthesia training here, went off to McGill to do 2 years of pediatric intensive care, and then finished off my anesthesia fellowship when I came back. What do we start is the question that I probably get the most when I'm on for PICU from residents. So that kind of spurred part of the discussion, and so describing sort of a rational selection of vasopressors and vasoactive agents inside the unit. So we're going to talk a little bit about the shock states, but really expand on what Leah was describing, is that really taking each of them individually and describing, you know, what are we giving and why are we giving those agents in relation to those shock states, and then discussing the rationale behind those selections as we sort of go through it. I don't have any separate disclosures, no companies that I work for that produce these medications. And overall, I think as a summary, you know, selection of any of these medications really depends on what you're trying to achieve for each of your patients. Taking all of that clinical information, investigations that you have for them, whether it be echo, biochemical values, to decide on your sort of your most appropriate step. And then while all of us, I'm sure, are familiar with PALS or NRP, that really important piece of reevaluating every single step that you've made, because as Leah mentioned, this isn't in a vacuum. You know, all of these patients are very fluid and dynamic. So every time you've made a change, you really have to go back and see what that change has done and where to make your next step or next move. When talking about shock, Leah did a great job of sort of going through it, and we're going to focus specifically on oxygen delivery through all of this. Essentially, we're in a point where we're not meeting cellular demand. So when we're looking at oxygen delivery or oxygen consumption and use within the body, we're really looking at oxygen delivery versus consumption here. And some of you may recognize some of the equations for it, but really looking at VO2 or VO2 max in sort of the exercise physiology world, and then DO2 or delivery of oxygen delivery to make sure that you've met sort of your demand through all of this. And a lot of the states that we get into with our shock states are really going to change that dynamic and push us into one realm or the other. The graph here, looking at VO2 versus DO2, the red line and blue line, there's a sort of an obvious inflection point between the two, and that's called our critical delivery of oxygen point. Anything to the right of that is really going to look at sort of the normal side of the curve, the normal state that, you know, we're typically resting in, where our VO2 or our demand and consumption of oxygen is completely independent of our delivery, you know, meaning that all of our cells are able to participate fully in aerobic metabolism. You don't really have lactate that's being produced. But then when we start to shift towards the left side of the curve, we can start to see that we get into a more sort of shock-like state where our VO2 is completely dependent on what we're able to deliver. And if we need more energy beyond that, we then have to rely on some degree of anaerobic metabolism. And then you do get production of lactate. And eventually, if you stay or persist in that phase and have an increased ongoing consumption that is not being matched by your delivery, you start to have end organ dysfunction or cells that are unable to function the way that they need to. Quickly looking at delivery of oxygen, there is the arterial content component of it. Saturation we can modify, hemoglobin we can modify by blood transfusion. But really, when we're looking at vasoactive agents, we're really looking at that cardiac output piece. So stroke volume, which is preload, contractility, and afterload, which are already defined by Leah there, and then heart rate. And so we're going to talk a little bit about what those changes are in each of these sort of shock-like states and what we can do to modify them. Really looking primarily at the hypovolemic, distributive, and cardiogenic shock states. Part of the reason we won't dive too deep into obstructive and dissociative shock states is because a lot of the times you won't be using your vasoactive or inotropic supportive agents unless you absolutely need to in those states. Really what you're going to be doing for something like obstruction is relieving that tamponade, managing that pneumothorax with chest tube, or finding a way to lyse or improve the flow by a removal of the PE. In your hypovolemic, distributive, and cardiogenic shock states, you're more likely to have to need some sort of external support because your endogenous support just isn't enough. We touched briefly on the compensated and uncompensated states. Some of this is from learnpicu.com, just because I find their summaries are actually pretty nice from a residence perspective. Compensated, where your organ function is maintained, although you may have some physiologic changes such as your tachycardia. You may have variations in your respirate, but typically it's within the normal realm. Cap refill should be reasonable, and you might get some oliguria and agitation, but overall, as Leo was mentioning, is that your BP remains normal. BP dropping is actually usually a sign of uncompensated shock states, where you might have some degree of organ dysfunction, even if there isn't obvious irreversible cell death. But there's usually some degree of as they mentioned, sort of microvascular failure, but you might become more tachycardic, more tachypnic with a change in your cap refill time. Anuria is often in this state, and then you can confusion or coma due to poor perfusion into multiple organ systems as described there. And then we get into an irreversible point where you get multi-organ dysfunction and essentially death of cells within multi-organ systems, whether it be in HIE or acute kidney failure, liver failure, ARDS within the lungs, or possible myocardial infarction, and then even coagulopathy and DIC as part of your immune and hematologic components of your system. This table, we're going to go through it a little bit more closely and apply it to a couple of different scenarios that we are likely to see. And we'll highlight a couple of the different agents that we have on there. But when we're selecting vasopressors, if you really think about it, or what's sort of going through my head is, what effect am I really looking to achieve for the patient? What am I thinking about based on their vital signs, their lab investigations? Where's their lactate been going? What is their acid-base status, et cetera, as a way of trying to fit together what is going to be the best agent that I can potentially select for this patient. And then, along with all of that clinical information is like, who is the patient? How do they examine? What is their age? What is their sort of normal physiology that I'm trying to get them back towards? Because that does vary by age. And that's, one of the beauties of dealing in pediatrics is that we deal with patients from the neonatal age all the way up to essentially early adulthood, where the physiology changes dramatically over that 18 years or 21, I guess, if you're in the States, that allow you to really sort of exercise all of those physiologic parameters and really have to keep you on your toes while you're trying to figure that out. Then, when does it really matter which agent you select? Does it always matter, or are there multiple options that are available to you? And then really, what are vasopressors doing? And, the reason for that picture there is because a lot of the times the vasopressor that you select is really just a Band-Aid. It's going to help you provide the patient time to either improve from their infection, give you time to supplement additional fluid, keep up with ongoing hemorrhage, replace steroid if they're steroid deplete, and give you the chance to sort of figure out and figure out what's really the underlying issue that you have to treat. Very rarely is the vasoactive agent in and of itself going to fix the overall problem without some underlying additional support. When thinking about sort of the clinical components, one of the ones that we talk about commonly is cold shock versus warm shock. Within your cold shock sort of states, you often have that impairment of your preload, afterload contractility versus your warm shock states, which is often a SVR or vascular tone phenomenon with a widened pulse pressure. And that's probably one of the most defining points that we use for our shock states on sort of clinical exam at the bedside with each of our patients. When we get into sort of our shock states and talk about hypovolemia as our first one, the mainstay of therapy is fluid. And we've had a number of these actually come in my first 2 years here of like very profound dehydration from whether it be, actually most of them have been from ongoing sort of GI losses, but just profound dehydration with the idea being that volume is really what they need, but it does get difficult to continue to, provide fluid to these patients when you've already provided 40 mLs per kilo, 60 mLs per kilo ongoing. And so a few of the times that I've had these patients, I remember one that I did with a Duncan, at least over the phone, was the idea, and I think Dr. Grip, you might have been there too, is the idea that we need to support them somehow while we continue to do that ongoing fluid resuscitation. So selection of fluid kind of depends on the situation. Is it crystalloid? Is it colloid? And if it's ongoing hemorrhage, then don't forget that there is that massive transfusion protocol that we do have available here at the Children's, which is including the OR, the ER, and ICU. But primarily what you're really trying to work with here is that you've got a significant drop in your preload, and all of that filling needs to be replaced in order to actually be able to have the body function appropriately. So ongoing fluid administration, and then using pressors if you need to, as a Band-Aid to help give you time to continue giving all of that fluid that's needed. Because your afterload and contractility aren't necessarily directly impaired by all of that. It's that they're able to manage that if they have the appropriate volume available. When looking at your cardiogenic shock states, really what are you trying to achieve? If you think about what you're usually dealing with in your congestive heart failure, your myocarditis and arrhythmia states, your preload is often high because your pump isn't working as well. Therefore, your contractility is really low. And sometimes you might be working against a increased or normal afterload. And the problem is that it may be abnormally normal in that your heart is just not able to function against what would normally be there. And so we really look at milrinone and dobutamine and how different are they really in their effect. Leah kind of touched on some of that. So if you think about sort of dobutamine and milrinone at the bottom of that table, primarily initially looking at dobutamine working through beta-1 effects, it has a drop in your SVR, an increase in your cardiac output, and a relative sort of stability of your blood pressure. And then you have your titration goals. Whereas milrinone works through a different mechanism with phosphodiesterase inhibitors. It has a slightly more profound drop in your SVR, and potentially with that, a more significant drop in your blood pressure. But both of them maintain, or I should say, work to improve your cardiac output. With the milrinone, I find that more often than not, at least in pediatrics, we tend not to do the load. So I find that you get less of that dramatic drop in your SVR. But the idea that both of these agents could potentially drop it, I think having that backup option available of what am I going to do to help manage that SVR if I need to, and that's where the combination of different agents will come into play of something from the top of that table, whether it's epinephrine, norepinephrine to help boost your SVR as a way of maintaining that forward flow and balancing out everything that's going on related to your agents. But really, if you look at it, they're essentially achieving the same effects overall. And depending on where you work, you'll be able to see that different people will select different agents. But I don't think there's actually a right or wrong answer for the two of them. I think local practice seems to be more milrinone, and correct me if I'm wrong on that, either of my colleagues in NICU, or I think I just saw that Dr. Kessman's also here, but milrinone seems to be the more commonly used local practice agent. And sort of going on into it, I can come back to that, Darcy, if you want, looking at sort of onset times for some of these agents. Distributive shock states. So if we're talking about anaphylaxis, specifically for anaphylaxis, epinephrine is the agent of choice. It actually just works to correct all of your different issues, including sort of mast cell stabilization. It also allows improvement in your ventilation or reversal of impairment in your ventilatory capacity through its beta effects. And then also support of your blood pressure, support of your cardiovascular system to prevent collapse with support of your beta-1 effects. So really in that setting, I feel like there is a very clear winner in what you're going to deliver. And obviously early delivery of that agent can really, really save someone's life. So important to keep that in mind. From a neurogenic perspective, there's no clear-cut answer regarding whether you would have epinephrine or norepinephrine as your mainstays of treatment. A large part of it is going to be that drop in afterload that you're trying to correct. And so what I would say is, depending on where you are, some people will choose epinephrine, some people will choose norepinephrine, but the evidence is mixed on it, and you can actually use both as long as you're really maintaining your goals of sort of obvious sort of mean arterial pressure that you're trying to maintain for these patients to ensure that you've got appropriate flow for each of their states. Then we get into sepsis, which is another distributive shock state. A lot of the question comes from epinephrine versus norepinephrine for these patients. And then it's really, what are you trying to get out of it? So you've got that drop in your preload from redistribution, you've got that drop in your afterload from the vasodilatory state, and you might get into a point where you have this sort of change in your contractility where you might have these very obviously collapsible ventricles on echo, but you may not always have your echo available to you. When you look at it, so if you're looking at epinephrine and norepinephrine, these are mixed alpha beta agents. So you've got your low and high dose, as Leah sort of put into this table, and then you've got your norepinephrine, which essentially has primarily alpha with secondary beta effects. And the reverse is true for the sort of low versus high dose epinephrine. So low being primarily beta, then secondary alpha, and then higher doses being largely, mixed, like a direct mix of alpha and beta effects for your epinephrine. But they'll all actually increase your cardiac output. You'll have a primarily stronger increase in your stroke in your systemic vascular resistance with norepinephrine, and thus hopefully an increase in your blood pressure as well. But if you think about it, this is actually a one-pager from Nick Mark, who is a adult intensivist, I think, out in Seattle. He actually runs the one-pager for ICU. It's actually a really fantastic Twitter page as well, or Twitter feed. But if you look at them, norepinephrine and epinephrine are not actually that different. You get into sort of phenylephrine on his sort of wheel, phenylephrine being primarily alpha, and then you'll have your dobutamine and isoproterenol, which are more sort of into the inotropy side and chronotropy side. But between norepinephrine and epinephrine, the jury is really out as to what is your best option and what is your best potential agent to use. And really, when we get into septic shock or shock states that have this sort of distributive factor, I think what you're really looking at from a first line perspective is, what I usually ask myself is there evidence of cardiac dysfunction on echo? The hard part is that you aren't always there at the bedside. You don't always have an echo to go with. And I think that is one of the reasons that epinephrine is often more commonly chosen for management of these kids, is that you don't necessarily know, and if they present with any evidence of a potentially cool shock-like state where you're worried about cardiac function, I think it's very safe and reasonable to add your epinephrine on there. If you do have an echo and it looks like their cardiac function is preserved overall, then it may not be unreasonable to actually just go ahead with norepinephrine as your first line agent. The other piece to keep in mind is also with our younger patients, so our neonatal population and infants that we have that come into the unit or through emerge that benefit from what is a sort of a rate dependent cardiac output. We really want to preserve that heart rate to keep that forward flow. They don't often have cerebrovascular disease. They don't often have cardiovascular disease as they would in the adult population unless they have some sort of reason for accelerated coronary artery disease. But in that case, you really want to maintain that heart rate, and epi, even in the lower dose, will likely maintain that heart rate just a little bit better than norepinephrine without having to get to those higher doses and get that significant beta effect from the norepinephrine. But if you to pull in some actual, I guess, guidelines, the Surviving Sepsis Campaign, I think this was an update from 2020 or early 2021. No, this is 2020 because I think the 2021 is much more COVID heavy, not surprisingly. Vasoactive medications and their recommendations for management of these types of scenarios. So there are suggestions from 28 up to 32, I think, are related to their vasoactive medications. And you can get this from the SCCM website if you wanted to review it yourself. But they suggest using epinephrine rather than dopamine in children with septic shock, much like Leah would suggest. They also suggest using norepinephrine rather than dopamine in children with septic shock. Clearly no love for dopamine anymore. Although I think there can sometimes be a role for it, and we will get into that in just a little bit. But they're really unable to issue a true recommendation as to what their first line agent would be for children in septic shock. Practice will vary from epinephrine or norepinephrine as your typical first line agent. And through my training, I found that different practitioners will choose different agents. And I don't know that there's always a very clear rhyme or reason regarding that. I think a large part of it is that you can actually pick both and you can use them appropriately and still manage these patients very well. And I think really what it is, it comes down to the way you're monitoring, assessing, and sort of doing your serial management of that patient, that you will flip back and forth or decide on what is your next best step before you go on. The recommendations of 32 and 33 related to sort of vasopressin. It's actually really interesting because the adult literature would strongly support vasopressin as your secondary agent, with norepinephrine being your first agent. I haven't found a lot of centers that actually use vasopressin very regularly. However, it does make sense as a second line agent, depending on what you're seeing. I think it's obvious from the table that Leah put up there, though, is that at high enough doses, your epinephrine and your norepinephrine are doing very similar or having very similar effects on the physiology. If you're looking for more correction of vasodilatory state, I think vasopressin makes a lot of sense. There is some evidence to suggest that vasopressin, at least at the start of your septic states, you actually get into a peak of your vasopressin from use of your endogenous stores, and then you may have a drop off and sort of return to sort of normal levels of vasopressin, which likely doesn't help or could potentially prolong your sepsis or a shock-like state. And so some of the literature on that is looking at, is there a role for replacement of your endogenous vasopressin? And through the anesthesia world, I've seen some people that will actually replace it in sort of micro boluses until you get to a sort of good response state, and then start an infusion as a way to essentially get back to a semi sort of stable state before just initiating the infusion. Whereas others would say that, there's no real consensus as to when do you start it, at what dose do you start it. Although I think the milliunits per kilo per minute is a very reasonable starting point, and that's what we would use in our center here. The other piece that came up, and Leah, it contradicts a little bit of what you're mentioning, is that there is some evidence in at least animal models that for vasopressin itself, it's actually potentially very good to use in specifically pulmonary hypertension patients, where you're trying to maintain that SVR and sparing some of that pulmonary vascular resistance. That's in, I think, rat models and pig models that looked at a minimal change in your PVR with vasopressin while maintaining or significantly improving your SVR. And so I think for some of the pulmonary hypertension literature specifically, and I can't say that we've had a ton in my first 2 years here through the PICU, although I'm guessing through the NICU that you might see more of that with some of those infants that are coming in or neonates that are coming in with uncorrected congenital heart disease and trying to manage that, where vasopressin may potentially actually be a very good agent to use help support their status. And then regarding the sort of use of any sort of inodilators, so your dobutamine and milrinone, the evidence really doesn't, there isn't specific evidence to really support that use. However, you may need that if you have ongoing cardiac dysfunction despite adequate or ongoing sort of cardiac dysfunction as evidenced by poor perfusion and end organ dysfunction, despite adequate vasoactive agent therapy. And I think that's where that sort of clinical acumen and sort of assessment at the bedside and ongoing biochemical assessment is really important for taking a look at those patients. We covered some of that. And then just quickly to go through these, I'm sorry that we're running late. Phenylephrine, yeah, so you won't really use that in any of our units. And I don't think I've seen it used ever in the ER, but correct me if I'm wrong, any of my ER colleagues that are on the call. The reason for phenylephrine, even in peds anesthesia, we use it a lot less. You'll see it a lot more in the adult populations or sometimes with older kids, probably in their late teens, where people will often use it as a way to provide some alpha stimulation, just to maintain that SVR. Usually I find it's used more so for incidental. A good example would be when intubating or in the OR, if they have, to provide deep general anesthesia as a way to quickly undergo the anesthetic, or for intubation, that people will often use it as a way to supplement their blood pressure momentarily. But once again, like that's very, very limited use. I suppose the one time where you could make a very strong argument for it would be in like critical aortic stenosis, where you're really trying to maintain that SVR. Although you'd probably make the argument, why not just use norepi or epi and get the mix. Vasopressin we kind of touched on already. And then for dopamine, I'm not a huge fan of dopamine specifically. I find that there are other agents that you can use that are a little bit more targeted. The one good example, I think, for use of dopamine, though, is that if it's something that's pretty easily already pre-mixed and accessible. So if you needed something quickly without having to deliver a resus dose of epi, or to have someone dilute up your epinephrine or norepinephrine, it's something that's there's a reason that it's already pre-mixed and available, is that it's something very quick to start while you decide where you need to go with one of your other agents. Overall, I think, once again, the selection depends on what you're trying to achieve, considering all the information, and decide on sort of what's your most appropriate step, and then reevaluation. We don't tend to have sort of frequent echocardiography. I know that we've got some new ultrasounds that have come into the hospital now that actually give you the chance to do that. And I think that's going to be something that we'll be doing more and more of at the bedside. I know that Jeff does a lot of it. But something that you can use more and more at the bedside to get a better sense of what overall is happening, and then help guide your therapy further from there. But there's really no perfect single agent in most situations. But the key is to just pick whichever one fits best in those moments. And I'm going to stop sharing, and we can hopefully get into a small discussion. Sorry, I saw that the chat was having more and more.
The chat's blowing up. No, it's not, but I will go back to, because I know that people were kind of putting through questions as I was talking or as Ravi was talking, so I will just kind of scroll back. I'm going to keep the recording going if people are okay with that. But if you feel that you want to ask a question that you don't want to have your name attached to, you can like direct message me in the chat. I think if you send a message to everybody in the chat, it does somehow go onto the recording. But if you don't want to say it out loud, you can send it to me privately and I can just read it out loud. Did you have anything you wanted to handle first, Ravi, or can I just start at the top?
Let's just start at the top and let's go.
So there was a question when I was talking about vasopressin in terms of, does it have an effect on the gut, decreased perfusion, so does it contribute to neck, and specifically asking about vasopressin. And I would say I don't have, and maybe Ravi, you can correct me if I'm wrong, I don't know if there's specific literature connecting like an association between neonatal receipt of vasopressin and increased neck rates, but I know that in a patient who's sick enough that we're giving vasopressin, we're not going to be feeding them. In terms of whether that increases your spontaneous neck rate anyways, I'm not sure. I would say that physiologically would make sense. I would expect vasopressin to vasoconstrict in the mesentery and other vascular beds feeding the gut. I can't see why it wouldn't, vasoconstrict there just like anywhere else. But in terms of like specific evidence linking it to a specific higher incidence of neck, I don't know about that, but maybe if one of the neonatologists on the call, or Ravi, if you know anything about that, you want to hop in, feel free.
That came up actually during fellowship. One of our, I guess the only two places that have a surgeon in their ICU is Montreal and Winnipeg. Pramod Puligandla, and he kind of described that at least when he's on vasopressin, when he's on norepinephrine, I don't think there's clear evidence to say that there's an obvious baseline increase. But his point is that why would you stress the gut anymore when you already have a decreased flow state? So his thought would be to tend to hold off. I don't know if BJ is on this call anymore. She was having trouble joining in, but I'd love to get her take on it. But I don't know if anyone from NICU has a very clear evidence on that, but I don't think that there's something that we found, at least in the last, like when I was back in fellowship, that pointed to a clear baseline increase.
And in terms of like whether any specific pressor choice, like when you have an infant that's that sick, whether any specific pressor choice is going to be worse or better in terms of increasing your risk of neck, at that point, I think it's honestly a coin flip. And that's just based on what I've seen from working there over the years. Again, I'm not familiar. Maybe there is evidence trying to look retrospectively at did certain pressors have an association with fulminant neck or not, but I'm not aware of it. So if any of the neonatologists know of anything and want to hop in, feel free.
This is Ayman, one of the neonatologists.
Okay.
So regarding the vasopressin use in neonates, I think it is more related, or the complications are more related to decreased renal perfusion, but I don't think, or I'm not aware of any known increase in the incidence of neck or decrease in perfusion of the gut. I have no knowledge of a literature describing increasing neck or decreasing perfusion while the baby is using the vasopressin. The main thing is renal impairment and hyponatremia, as you mentioned. Thank you.
Oh, thank you. So just moving on here. Some people forwarding a copy of the table. I can definitely, Dr. Grip, bring some of those cards down to Emerge if the staff would like them as well. The table was approved by Ravi when I made it up, so it is not just my own baby. It was approved by another person. So I made them all, so it might take me a while to make more. But once I do make more, I can bring them all. I can bring some to NICU and bring them to Emerge. But also Susan said we can get more of them made. So Susan, if you know a better way to make them than me getting one of those like big paper slicers and laminating them all myself, if you know a better way to do it, please let me know, because it took a long time.
I'll volunteer our emergency admin, who's very good at that kind of thing.
Okay, perfect. Tracy Ridley had said, good picture in our recess room. So I can forward you like the singular file if you guys would like to print it in a bit of a larger size and put it on the wall, if you think that would be helpful. We had a copy. It's a bit of an amended copy. We have something similar hanging on the wall in the PICU pharmacy, and a lot of people have found it helpful. So I can send that in like the whole file if you want it. So do you want to speak, Ravi, to Darcy's question about onset times for, effects of dobutamine versus milrinone?
Yeah, so Darcy, that's a great question. The onset times that like I've usually thought of for dobutamine is like in the realm of minutes for really like getting an onset with a peak. I think like in 10 to 15 or something like that. The problem with it is, I think, as another question was mentioned about the tachyphylaxis that you can get with dobutamine. So that probably wouldn't come into play, I'm guessing, for you guys in the ER, since they're only with you for a short period of time. Whereas I'm not familiar with a significant tachyphylaxis with milrinone, and correct me if I'm wrong on that, Leah, if there's some evidence from the pharmacology literature. But I think that's one of the reasons that we tend to use it as Marie's mentioning, that milrinone is favored to here locally. The other piece about it would be that for the milrinone onset, although the onset technically happens, I think within like 5 to 15 minutes or like 15 minutes, the issue that we often see here is I find you'll get a slower onset because we don't load. And I think part of that is because we're, the load is not without its own risks. And you're often dealing with patients that are already quite tenuous and in these states. And so you want to sort of give them some time, especially if they're sort of holding their own or allowing you that time to slowly get it in, then you can do that load over time with just the regular infusion and then go from there. Very rarely have I seen a load actually done for pediatric patients. And I don't know if that's done at all here, or if you guys have had to do it in Emerge or not. And then the peak onset for milrinone, I'm not sure I have a specific peak onset, but I usually find that without a load, it at least takes a couple of hours for me to actually see an effect from the milrinone. And I'd say somewhere between 2 to 4 anecdotally, because I find that it takes at least about 4 hours for me to see a significant change after I shut off the milrinone.
Yeah, and that was kind of my question, is I vaguely remember this from residency and fellowship, but that it takes a while. But I don't know if it's reasonable to do something between a load and a standard infusion. Like it'd run at a higher rate for 15, 30 minutes or something. And then
I'm sure pharmacy would love that. When we go off.
But I get an order from Emerge for like milrinone at 1 microgram per kilo per hour for 30 minutes and then go down to 0.25. I'm gonna be like, what the hell is this?
I just, I don't really ever want to do it without somebody else's guidance anyway, but just that slow onset was something to think about, I thought.
Yeah. And then there were some comments from Murray as well. Murray, I don't know if you want to hop in to speak a little bit about your comments, or if you want me to just read them out. I think he's still there.
Leah, I would always rather jump in than have you speak for me, you know that.
Of course. Go ahead.
Anyways, yeah, well, milrinone, I think, is just a gentler agent, and we used to load it, but did run into trouble with hypotension and felt that it wasn't worth it. You're going to live with that side effect for quite a while, so that it was better to just start it and maybe an hour or two until you get to some reasonable effect. But it's hardly ever used in isolation. I mean, sometimes it is, but if someone's really sick, you'll be starting that as well as something with more inotropy, depending on the clinical situation. Vasopressin, my impression is that adults have way more vasodilatory shock than kids do. Kids tend to go through that phase to cold shock much quicker, and hence kind of the role for a vasoconstrictor is, I think, is much more common in the adult world. But certainly we do try it with refractory vasodilation. And before I left, I used to find it was kind of bleeding into people just using it probably for no good reason, but just because they'd run out of other choices. So I don't know if that still goes on.
Actually, don't think I've run vasopressin on somebody in PI for quite a while. It's been a while, other than a couple of recent like organ donor scenarios.
Yeah.
It's been a while.
Yeah, that's a different scenario, right?
Yeah. And one of the ICU nurses on the call actually also made a really good point that I often forget about, actually, even coming from a pharmacy perspective, that from a nursing logistic piece, milrinone's half-life is much longer. It's like a couple of hours on average. Dobutamine, very short, couple of minutes more like. So when nurses are doing syringe changes and having to do double setups and all that kind of stuff, it's a lot, I guess, potentially safer and smoother for them to do infusion changes with milrinone, because a brief interruption in the infusion is going to be a lot less problematic than a brief interruption in a dobutamine infusion would be too. And that's a very good practical point to make. And I, one of the things, Ravi, that you mentioned about the benefit of dopamine being available pre-mixed in a lot of places in the hospital, especially in places like NICU, especially overnight, and emerge and things like that. At least in PI, we have the one pre-mixed bag of the norepi at the peripheral, like the peripherally safe concentration. So there is that option. It's not always ideal in terms of nursing for a small child. Like they can run it, they may not have the appropriate pump in the room and all that kind of stuff, but it is there just in case we're not able to slap an infusion together right away, right out of pharmacy. Cool. Anybody else have any comments or questions, things they want to talk about? Can leave if you need to, because this has gone a little bit longer than we originally slotted it in for. Be offended, but if anybody else wants to chat more. No? Thanks, Sarah. A great presentation. Okay, I'm going to stop the recording there then.